Hello and welcome to Triage, rapid legal lessons for busy healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Hello, my name is Matt Huddle, and I'm a partner with K&L Gates Investigations, Enforcement, and White Collar Practice Group.
And my name is Stephen Bittinger. I'm a healthcare partner that works with Matt frequently on healthcare fraud investigations and False Claims Act defense.
We are here today to discuss the Office of Inspector General's recent addition of two new items to its work plan. One, auditing of COVID-related reimbursement during the public health emergency, and two, auditing of CARES Act provider relief funds. A key component of HHS OIG's mission is to detect and root out fraud in federal healthcare programs, including Medicare and Medicaid. OIG's efforts to curb fraud include conducting criminal, civil, and administrative investigations of fraud and misconduct related to HHS programs, operations, and beneficiaries, using state-of-the-art tools and technology in investigation and audits around the country, imposing program exclusions and civil monetary penalties on healthcare providers because of criminal conduct, such as fraud or other wrongdoing, and negotiating global settlements in cases arising under the Civil False Claims Act, developing and monitoring corporate integrity, and developing compliance program guidance. The OIG also works directly with the Department of Justice and U.S. Attorney's offices around the country to investigate and prosecute both civil and criminal healthcare fraud. OIG agents assist local U.S. attorneys by investigating, evaluating, and referring potential cases arising from a wide variety of sources, such as audits, data mining, and whistleblower complaints. Currently, DOJ and OIG are closely cooperating in task forces around the country to investigate and prosecute fraud arising out of COVID relief programs in the healthcare arena. Also, at the direction of the Department of Justice, coronavirus fraud coordinators have been appointed at each U.S. Attorney's office to facilitate investigations and prosecutions. As one example, the U.S. Attorney's Office for the Northern District of Texas announced last week that it entered into an agreement with the Office of the Special Inspector General for Pandemic Recovery to investigate and prosecute CARES Act-related fraud. Given the massive amount of federal funding dispersed under these COVID relief programs, providers should be keenly aware that their application for and use of these funds will likely come under strict scrutiny by the whistleblower bar and a wide variety of federal law enforcement officials, including the OIG. Indeed, the DOJ announced just last week that it had charged 57 defendants to date with attempts to fraudulently obtain over $175 million in Paycheck Protection Program funds. Some of these charges have been brought against individuals in connection with ongoing healthcare fraud investigations, including allegations of PPP fraud related to Durable Medical Equipment Company and a chiropractor's office in Florida. The alleged conduct related to the DME company was particularly egregious, as the U.S. Attorney's Office for the Southern District of Florida alleged that PPP funds were used to pay kickbacks to referring physicians for medically unnecessary DME.
Thanks, Matt. Yes, my practice is focused on the regulations and data that surrounds these types of audits. The OIG conducts these types of audits by hiring outside contractors to review that data. They select targets for review, and they provide analysis, which is where my work really begins. As most people are aware, CMS announced early after the pandemic hit that Medicare would be paying an increased weighting factor in the assigned diagnostic-related group, or DRG, of 20% for patients diagnosed with COVID and treated from January 27th of this year through the end of the public health emergency, or PHE. For anyone that does not work in the inpatient reimbursement arena, the 20% does not mean the hospitals are getting 20% directly on top of what they normally would be paid, but for treating that patient. But the 20% weighting does go into the formula for the DRG and cause an increased reimbursement based on the rest of the DRG factors. To provide some context, the OIG released a report by the Government Accountability Office, the GAO, on August 31st, highlighting some of the major government responses to the pandemic as of July 31st. And they focused on 6 major areas. First was business loan programs, and there is $538 billion that has already been spent of $687 billion appropriated, so funds set aside. The second one is economic stabilization and assistance. There's $500 billion that's been appropriated, but only $30 billion of that spent so far. Third major category, unemployment insurance. $376 billion was appropriated, $273 billion has been spent. Fourth major category, economic impact payments. So $282 billion was appropriated, $273 billion was spent. Fifth one, which is public health and social services, and this includes a lot of our elevated reimbursement or reimbursement programs. There was $231 billion appropriated and $129 billion spent so far. Sixth, and a major aspect that the GAO investigated was the COVID relief fund. All right, so this is our provider relief funds. $150 billion was appropriated, $149 billion has been spent. So most of the door is already out the door in the major reimbursement and provider relief programs. This totals $1.4 trillion of the $2.2 trillion that will be spent. It's important to understand that the offices of Inspector Generals for different divisions of these funds will be overseeing auditing for each section, but the OIG for the Department of Health and Human Services, or OIG HHS, that just released the work plan items for the COVID reimbursement and provider relief funds will be focused on that $129 billion spent on public health and social services and the $149 billion spent on COVID relief funds. All agencies overseeing these funds have deadlines to report data of how those funds were used approximately 2 months after each quarter closes. It's important to remember that the OIG is required by law to follow the the GAO auditing or Government Accountability Office auditing standards, which means that there are a set of rules that the OIG is supposed to follow, and they're supposed to make sure their contract auditors will follow. The GAO auditing standards can be a very powerful weapon for defense of abuse of the audit processes. The OIG announcement of adding COVID reimbursement to the work plan last month was actually preceded by CMS releasing a Medicare Learning Network, or MLN, article on August 17th, which specifically informed inpatient hospitals, long-term care hospitals, and inpatient rehabilitation facilities that as of September 1st, 2020, all claims submitted for the elevated 20% for treating a COVID patient must have a viral laboratory test confirmation in accordance with CDC guidelines in the patient record. And that confirmation can be no earlier than 14 days prior to admission, or it can be during admission. The MLN also puts providers on notice that lab results from outside the hospital must be manually entered into the EMR. They need to be evidenced in the EMR record. CMS intends to conduct post-payment reviews to confirm lab tests results are in the record, and they will recoup if it's not found. Hospitals should manually self-audit. That was the clear recommendation of CMS, and decline or correct reimbursement claims if a proper lab result cannot be found. They also told providers that an updated Pricer software package would be released with additional guidance in October of this year. As reported by the Wall Street Journal last week, the American Hospital Association is pushing back hard on this CMS standard that there be proof of a laboratory test for COVID in the patient record. Hospitals must self-audit and refund if evidence of a confirmed positive cannot be found in the patient record. The AHA has asserted that this is an undue burden and also a challenge to the clinical decision-making of physicians who diagnosed patients without a laboratory confirmation. It is important to note that the OIG's focus on the elevated inpatient reimbursement audits does not mean that CMS will be ignoring the dramatically changed rules of outpatient services under the 1135 waivers during the PHE, and it is clearly expected that CMS will employ the usual RAC and UPIC contractors to review all of these services too. As the provider relief funds, Matt I recall we received some valuable guidance on these matters in our recent healthcare fraud and abuse town hall with some of the DOJ officials.
Yes, we recently hosted a national COVID-19 healthcare fraud town hall featuring the Acting Assistant Attorney General for the Department of Justice's Civil Division, the U.S. Attorney for the Eastern District of Texas, the U.S. Attorney for the Southern District of Florida, the U.S. Attorney for the Western District of Washington, the First Assistant U.S. Attorney for the District of South Carolina, and the Deputy Chief of the Civil Division for the Northern District of Illinois. These top law enforcement officials spoke to the extraordinary and high-priority multi-agency efforts to combat COVID-related fraud in the healthcare community. The government has clearly ramped up to combat fraud and abuse in these programs. At the same time, one message is that law enforcement officials generally do not want to use punitive tools such as the False Claims Act and criminal prosecution to investigate and pursue matters arising from mistakes or good faith errors by providers, especially during the current crisis. And indeed, the first wave of enforcement actions have involved allegations of blatant fraud and criminal activity, such as applications for funds by fictitious entities. However, as enforcement efforts and whistleblower actions develop and mature, we believe the focus will inevitably turn to large, legitimate, deep-pocket providers and more complex allegations of noncompliance. Therefore, providers should take great care to avoid becoming a target of government or whistleblower actions, especially during this period of intense activity in federal relief programs. Punitive liability, including treble damages and penalties under the False Claims Act, is premised on the knowing submission of false claims. Knowing means that a person, with respect to information, has actual knowledge of it or acts in deliberate ignorance of the truth or falsity of the information, or acts in reckless disregard of the truth or falsity of the information. And it should be noted that under the Act, no proof of specific intent to defraud is required. Providers should be aware that claims may be considered false in the traditional sense because they are factually untrue, but they also may be considered legally false in some circumstances when a provider submitting a claim fails to disclose noncompliance with material, statutory, regulatory, or contractual requirements. Thus, providers should take steps to decrease the risk of liability based on the knowing submission of false claims, including make and carefully document good faith efforts to comply with federal program requirements and evolving guidance, including careful documentation of the proper application for and use of funds. Special care should be taken to ensure the accuracy of all required program applications and supporting documentation and related certifications, which are specifically designed and required by the government to form the basis of both civil and criminal fraud enforcement actions. Law enforcement officials and whistleblowers will look first to these program certifications and applications as the triggers for potential liability. Thirdly, consult with legal counsel experienced in the ever-changing complexities of reimbursement issues under federal health care and COVID relief programs. And lastly, maintain and update vigorous compliance programs, a key indicator of good faith efforts to avoid the submission of false or erroneous claims.
Hey, thanks, Matt. As for proactive steps to take in preventing COVID reimbursement audits, it's imperative that provider compliance teams immediately build new internal protocols to ensure laboratory confirmation evidence is entered into the EMR, that providers are trained to ensure to look for this evidence, and that front desk staff is trained to gather all this necessary documentation. The compliance team also needs to identify any weaknesses that exist prior to implementation of these measures and take active steps to determine if an overpayment has occurred that should be refunded.
Thanks, Stephen. And we hope this update about OIG's audit plans is helpful to you. K&L Gates' multidisciplinary global team of lawyers is working collaboratively to help our healthcare clients navigate all the legal and operational issues arising from the coronavirus pandemic. Please don't hesitate to contact us and visit our website at the Hub tab, where you will find our extensive catalog of thought leadership and other timely resources on COVID-related subjects for providers. Thanks for tuning in today.
Thanks again for listening to Triage, rapid legal lessons for busy healthcare professionals. New episodes are available for download through iTunes, Google Play, and other podcast applications. By subscribing to Triage, you will receive timely notifications of each new episode. Also, if you have any topics that you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.